I'd like to now invite Dr. Gaurav Luthra. He's a brilliant phaco-refractive surgeon from Drishti Eye Hospital, Dehradun, and he has always been one of the best surgeons that we have known and very active in all the international symposia also. And we'd like to look forward to his talk on challenges in cataract surgery in presence of glaucoma.
Thank you, Dr. Anaga, and very good morning to everyone. Um, we've seen that cataract and glaucoma tend to coexist in the same age groups because that's the same age group where most people go on to develop cataracts and glaucomas. And so history of glaucoma surgery can also result in early development and progressions of cataracts. So the two things can coexist fairly often today. And with the increasing lifespan of patients, you have to be careful that once you have both glaucoma and cataract, then you have to decide what to treat, how to treat, and when to treat. So the treatment options remain with the coexisting cataract and glaucoma, that you could just go with cataract surgery first because you can continue the anti-glaucoma medications if the glaucoma is very well controlled. You may do the glaucoma surgery first, but that may increase the risk of cataract formation as much as 78% chance that you will get a cataract after a glaucoma surgery if you already had some. And you can go for a combined surgery. So it always remains a dilemma of what to do first or whether to do it as a combined approach. So each glaucoma surgeon would actually have an individualized approach for each patient. So when to perform only cataract surgery, usually in mild to moderate optic nerve head damage with well-controlled pressures on glaucoma medications. And when the field examination or the optic nerve examination is not very clear due to the high grade of cataract, you may decide to go ahead with a cataract surgery first to assess whether further surgery may be required, or even in ocular hypertensions with early 20s of pressures, you may decide to do just a cataract surgery first. So essentially, it's been seen that several of these studies have shown that there will be IOP falls following just cataract surgery, and by 2 to 3 millimeters, and this has been thought as one of the reasons that you can actually opt for cataract surgery alone or first in some of these patients that I just discussed. So in angle closure disease, of course, the EAGLE study compared the efficacy of clear lens extraction to laser PI, and it argued that the clear lens extraction was more efficacious and cost effective as a first line treatment, but that's again controversial because in angle closure disease, pupillary block is released and improves the aqueous drainage outflow facility. And intraocular pressure reduction was possible in both pseudoexfoliation patients as well as pseudoexfoliation glaucoma patients in the Shingleton et al. Study. And only 3% of 3.7% of glaucoma patients required further laser or glaucoma surgery. So this shows that pure cataract surgery itself can also give you some benefit in managing glaucoma in a select group of patients, but a pressure drop is not always likely, and in some patients you may actually see almost no change and there may actually be a higher pressure. But if you had a starting high pressure, then usually it's a strong predictor of a significant IOP drop. Now, during cataract surgery, you may face several of these problems, including small pupils and floppy iris and subluxation. Let's see this one situation where you can see there's it's a very shallow chamber with a small PI over there. I always prefer to do a laser PI in those patients where I'm planning a cataract surgery, or maybe if you're deferring the cataract surgery for a while, a laser iridotomy of course is essential. But even in those patients where there is a very shallow chamber and possibility of pupillary blocks, sometimes doing a small laser iridotomy gives you benefit during surgery because the surgery becomes less challenging, with possibilities of iris misbehavior being much less if you have a laser iridotomy in place. So essentially, you have to just remember that you're dealing with in glaucoma patients, you may have zonular laxity, you may have some subluxation. In fact, any eye which has a laser iridotomy, I'll be extremely careful right from the time of doing the rhexis, because many of these eyes you will notice that will have some kind of zonular weakness, and you may have even small subluxations. And the working space is much smaller, so you have to be careful that you have to protect the cornea, and the chambers are usually quite less, and there's little room for manipulation, so you have to do in the bag phacoemulsification or in the iris plane, but not bring it up superiorly. And surgery usually becomes with low IOP settings and a controlled way, so you should not be using very high settings, and you can actually get away with good cataract surgery. Some of these eyes, as I said, you have to be sure that you don't go into the equator of the bag and tug on it, because you'll cause a zonular dehiscence very, very easily. Here I'm using irrigating chopper, irrigating infusion handpiece, or the irrigating Y, basically to, it works like a third hand because you can manipulate the iris or the IOL and yet be able to complete the surgery nicely. So Again, choosing the right kind of IOL in coexisting glaucoma becomes very important, because if there are significant field defects, you may not want to use any of the multifocal lenses. I do occasionally use some of the EDOF lenses, but again, in those patients where there is no significant field defects, otherwise it's safest to go with a monofocal or a monofocal toric lens. As I said, small pupil requires management in these eyes, with several ways can be used. You can use phenocane, you can use viscomydriasis, and mechanical dilation, as I just showed. You should anticipate floppy iris syndrome in many of these eyes, so you can be better prepared for that with a proper incision. And I already mentioned about possibilities of zonular weakness, so these are the preoperative signs, which includes some phacodonesis or iridonesis, and also in the intraoperative signs where there is trampolining and during capsular excess, and some of these other signs which I mentioned on the right side. Intraoperatively, you have to be sure that you are not taking the IOP very high, and there should not be significant fluctuations, and a careful surgery with minimal iris manipulation. No ACIOLs definitely, and I think most of us don't use them anyway. And at the end of surgery, a good viscoelastic removal, and something maybe also to keep the IOP under check. Sometimes we give these patients a Diamox at the end of surgery, and also for the next morning, and we may start anti-glaucoma medication same day of surgery in the evening. Low IOP phacoemulsification becomes very, very useful in these eyes, because theoretically, it causes less damage to the optic nerve head, but also less fluctuations during surgery. So let's see, this is a patient who has a superior bleb, and here you have to be careful. I like to do obviously a topical clear corneal phaco. The challenge is that, if you're using trypan blue or viscoelastic, it will find its way into the bleb sometimes. Also at the end of surgery, sometimes, you will find that when you're trying to tighten the chamber, you will have fluid, the bleb may swell up. And very rarely I've had a very thin bleb rupture during surgery, because it does not take nicely to fluctuations of the chamber or even to any contact with the forceps. So if you're noticing, I'm only using a bud all the time. I don't like to hold the conjunctiva with any forceps, even with my routine surgeries. And that's very, very important when you have a filtering bleb in that area. You have to be also careful about how you use your chopper and the phaco tape. Let it not go anywhere close to those blebs. These eyes also tend to have much shallower chambers, because when there's a functional bleb, usually you'll have much shallower chambers, and there may be also a PI in that area just under the bleb, because trabeculectomy goes with a PI. So you have to be careful about all these things. Keep them in the back of your mind, and be minimalistic with your manipulations inside. Even the placement of your incisions has to be such that you are avoiding going close to the area of the glaucoma filtering surgery, and then you can get a great outcome. Usually it's not a problem, but sometimes with very thin cystic blebs or with overhanging blebs, you have to be extremely careful on how you are dealing with it. Otherwise the surgery remains mostly straightforward. Some of them of course can be very uncomfortable. This is a pseudo exfoliation where I prefer to do, it's a very shallow chamber with good amount of pseudo exfoliation. While you can obviously do this surgery with a routine way, but I prefer to manage it with under viscoat cover. As you can see, I prefer to actually do a femto, and here I've done a small stretch with viscomydriasis, and then in that small space you have to be careful that your chambers are well made, your incisions are well made, they are not leaky, otherwise you'll start finding iris prolapsing. So otherwise the surgery in pseudo exfoliation eyes remains mostly good. Even rotation of the nucleus in these eyes, you have to be very careful. If you apply a lot of force, sometimes you'll have a zonular dehiscence just with that much. And then of course placing the lens. I like to do hydroimplantation, because I don't leave viscoelastic at the end of surgery, and this ensures that I don't have IOP spikes post-operatively. I wanted to just show this last video, which is basically of a patient who had a neovascular glaucoma with a small tube shunt, and I'll finish with right after that. I think I've got the wrong video, one moment. I'm sorry, I think that video got mixed up with the previous one. Is this the tube shunt? Yes, it is. So let me just take you to the middle of the surgery. There is a small tube shunt which is not visible right now, but you have to be very careful in these eyes. You can see the bleb forming over here from the tube shunt, and it's a small pupil, and you have to be careful that you don't disturb it, and so incisions have to be very careful that they don't go very close to the area of the tube shunt. Let me just see why we are not able to appreciate the shunt at this time. So you can see it's a complex small pupil surgery with a very shallow chamber, and I think the tube shunt was just in the superior area, which I'm not able to appreciate myself at this time, so maybe the video has got mixed up. Anyway, so with tube shunts you have to be extremely careful, because these are the eyes which will have the possibility of some damage to the tube shunt at the time of surgery. And combined surgeries, of course, are, I occasionally do combined surgeries with patients who are on 4 drugs and there's no other way to go about it. You will do a combined surgery. And also in those situations, then you'll be able to promise the patient that you'll be able to bring them down with, 1 or 2 medications. And these surgeries are more challenging. I like to do a 2-site surgery. I don't do a combined phacotrap in one site. Cataract Plus is basically, I'll finish with this because I think we're out of time with this session. You can combine with MIGS, and there are various ways of doing the MIGS procedures intraoperatively during the same cataract surgery. The advantage is that you can combine the 2 procedures and the MIGS procedures or the KDB procedures. So these are the various procedures which are possible. The KDB can be done. You can do a GAT, you can do a TRAB, you can do a trabectome. They can be combined with the cataract surgery. You can use the eye stent. I've been using the eye stent for a few of these and got great outcomes in select patients as well. And with that, I would like to thank you because I think we are running out of time. Anaga, I'll be happy to answer any questions.
Yeah. Thank you so much, Dr. Gaurav, for that lucid presentation. Excellent pearls. Just one question. We all know that after glaucoma surgery, there could be a progression of cataract. So if the patient develops a cataract too early after the trab surgery and the bleb is functional, the IOP is well controlled, but now you are faced with a challenge that you have to undergo a cataract surgery. There have been studies which show that if you do it before 6 months after the trab has been done, there is a very high chance of bleb failure.
Absolutely.
So in such cases, how
So I would first work on controlling all the inflammation in the eye and ensuring that the ocular surface and the bleb and everything is it becomes quiet before you actually. You're right that I would actually wait for 6 months at least. But if you are forced to do it, there is a chance that there will be a bleb failure and you will have to manage that as well. But what steps you could take during surgery is to be extremely careful with how you are doing it. But I'm not sure what step you're asking for. Maybe you can tell us yourself what you would do in such a situation.
no, sir?
No, you go ahead then.
Okay. So what I was basically trying to say is once the bleb is functional and now we are faced with the challenge of doing a cataract surgery, even when you start with the first step like putting in the speculum, you have to be extremely gentle to see that the bleb is not touched at all. Take the main incision and the side ports as far away from the bleb as possible, and as you rightly showed, avoid making any kind of micro holes also or punctures in the conjunctiva using very atraumatic instruments. Avoid fluctuations in the anterior chamber and minimal trauma to the iris, minimal trauma to the corneal endothelium. Because if you have a very difficult cataract, we all know that the amount of phaco power used is also high. But fortunately, these are early cataracts, so with you have to use as minimal phaco power as possible. Try to minimize inflammation. In the post-operative period also, you need to be a little more aggressive to control the inflammation, because if there is higher inflammation, then it probably trigger a bleb failure. So, and monitor, and people have also advocated the use of antifibrotic agents like MMC or 5-FU at the end, or if you feel that there is a early sign of bleb failure. And sir, one question to you. We have seen how the new catalyst machines and all, they have the liquid optic interface, so there is not so much of actual applanation. So in in post-trabeculectomy cases, how much would you advise the use of flax?
Okay, so first answering your, just coming up from where you have said, the only requirement apart from what you said is that you need to be as far away from the bleb, and normally it does not disturb a good filtering bleb if you have done a clean surgery. As regards post-docking increase in intraocular pressure or with a functional bleb, because the docking is very gentle, I disregard the fact that the patient has had a glaucoma surgery. I still go ahead and do a catalyst with that. We have just completed a multivariate analysis on it. There are 4-5 factors by which post-docking, post-nucleotomy, etc., which increases the IOP to about 3 to 5 millimeters of mercury. And that is not at the time of docking, but after the docking has been removed, then you check. So first is the AC depth. If the patient has pre-operatively or at the time of operation For every 1 millimeter increase in AC depth, that means if you have a bigger AC depth, the pressure rises only 1 to 2 millimeters of mercury post docking. That means after the docking has, but with every reduction of that, the pressure can go up by 1 to 2 millimeters for every reduction of 1 millimeter. So that means that if you have a shallow AC, the chances of the pressure going up post catalyst is higher. The second thing that is there is it depends on the number of cuts that you are having in the nucleotomy. So it's better to have only 4 cuts rather than doing the softening. If you do more softening, because there is more bubble formation and there is more the bubbles which go around and the pressure can go high. So these are the two important things: the amount of energy that you are using by doing the nucleotomy, as also the depth of the anterior chamber. So these are two important things. But as regards if there is a bleb and there is a catalyst system, I'll go ahead and do it. And Gaurav, what you said, what is important is that you do an anterion and you see the lens thickness in such cases. If the lens is thick, you do whatever you want to do, a peripheral iridotomy will not going to help. So there the treatment, there is no confusion, you need to take out the lens, period. And the patient will be very happy, all requirements for drugs would go off. And I showed a case of 5.8 millimeter lens. So if you have such a thick lens, the treatment for that is to do a clear lens extraction.
But Mahipal,
Yeah.
you said about the pressure going up. That's only intra-op, no? Or later
No,
also?
this is what we have said is that after the patient is off the machine, we
Yeah.
then check the pressure.
Okay.
That-
But that's
at that
only
time.
during that phase.
No, immediately post
Okay.
post catalyst. So it does not remain high for a long
okay.
time. When you are doing it, that time it does go up to 30-40 millimeters. But even after that, there is an increase in pressure because the whole thing gets ballooned up. There is the fractionation that you have happened. So that is not significant. There has been, so that's what I'm saying. The pressure rise is about
Within
3
how
millimeters.
much time? Because
This
if
is
there's a
within
long
3
gap,
minutes.
okay, within 3 minutes.
This is basically when the patient gets up, within 3 minutes we have checked. We are sending it for publication, but the pressure rise is only about 3 millimeters. That's what I'm saying. Only momentarily when you are doing the docking. After that, the pressure rise is very limited for about 3 to 4 millimeters of mercury, nothing more than that.
Dr. Gaurav, just for the information of all, if you have cataract and glaucoma both and you're going to operate, what is it that decides whether you'll go only with cataract or you'll go combined?
So, if I have cataract, which is with glaucoma, which is very well controlled on 1 or 2 drugs, today, some of these patients, I will offer them a mixed procedure along with the cataract surgery. In the past, for those who are not doing mix or, otherwise I would have just gone with the cataract surgery. But again, especially in shallow chamber eyes, I will usually combine, I will do it purely a cataract surgery. But if I have a patient who's got, advanced field defects, 4 drugs, I will probably, want to do a combined procedure for them and not go with a pure cataract surgery, because I know that this patient will benefit from decreasing the number of drugs, better IOP control, and better possibility of adding drugs later on, in case you can bring down the patient to 1 or 2 drugs or even no drugs for some time. Those patients will have scope for putting them back on treatment down the line if their glaucoma progresses. So typically only with early glaucoma with minimal optic nerve damage, with minimal field defects, I might just decide to go with pure cataract surgery, especially with the shallower, with the angle, narrow angle kind of patients. But otherwise,
What's your mix of choice?
Sorry, I've been doing eye stents, but in my center we are also doing a lot of KDB, and I've only done a few eye stents. They seem to work, in majority of patients. We still don't have long-term data because the oldest patient I have is about 1 year. But I assume that over a year or 2 the effect tends to go down a little bit. But it does tend to give you that patient that benefit that you can decrease the number of drugs. Some of them who are on 2 drugs, we've been able to pull them off a drug for some time as well. So it does work, and it's an opportunity. It's just that it's too expensive. If it wasn't so expensive, I'm sure we would be using more of these eye stents in cataract surgery.
Thank you.
I think we are running already out of time. So thank you so much to all our speakers, and thank you to the delegates. Thank you. Thank you very much.
Thank you.